Please remember your evaluations because they need them to make sure that you have good feedback. And now, again, needs no introduction. Dr. Jernigan will introduce himself.
Actually, I'm not going to introduce myself. I'm going to introduce my topic. And my topic is going to be about hot flashes at the present time. What I am trying to do is I am going to go through some of the evaluation of hot flashes and show you some thoughts that are now occurring and try to bring it down to exactly what you have to do with it. I do not have any financial interest or arrangement. No one is paying me any money to give this lecture. It does fulfill a to-do list, so therefore I enjoy doing it. Likewise, I will not discuss any unimproved or investigative use of a commercial product device during this activity or presentation. I will be talking about several medications later on, but it's only briefly and they are in their generic form. What I really want to talk to you today about is hot flashes. I want to talk to you today about not only some of the misinterpretation that we have with regard to duration, but I also want to delve slightly into the bioscience of hot flashes. As I gave this lecture before, I was attempting to look at how we could relate this to what we do as gynecologists, with you all being obstetricians. Concept of preterm labor still bedevils us. Why does somebody go into preterm labor and somebody doesn't? So we try to look at what causes labor. Well, what we're starting to see in some of the literature with regard to menopausal symptoms is what causes, as they're now looking at heat disparation responses, causes a response by a patient that may be minimal, a cup of coffee, a change in environment, simply stepping outside, a shower, which temperature may be just a little higher than usual, and they can't put on makeup. Why does that person have horrific hot flashes? And you'll see in some of the studies that we're talking about, the hot flashes that they're having per week are greater than 50 to 75. So they're having a significant number of hot flashes. Why does one person have this as opposed to another person? So we're looking at the science of this. All of you know that I am a historian, so of course you know I'm going to find some type of historical fact. In fact, the first part of this lecture will be basically looking at history. This is from the 1500s BC, and it says very politely, "She recovers after the vomiting, then say to her, 'This is rising of blood from the womb.'" In other words, she's having a hot flash that's causing nausea and, in this patient, vomiting, which does occur, by the way. I've had patients have significant problems. But let's talk about a more modern time, the 1800s AD. Basically, we started looking at what was causing hormonal changes. I've given lectures in the past which we've talked about the use of testosterone injections in ball players. Not in the year 2000, in the year 1890. So we have an interest in what's happening hormonally during that very critical time of medical care development, the 1880s to the 1910s when Flexner gave his report. Realistically, further research really started when we started to find out about conjugated equine estrogens. These became marketability in 1943. So to look at what was going on, these were looking at what was happening to the patient and why she was having hot flashes and what would help. More realistically, Don Gambrell, who I knew personally, and Malcolm Whitehead, who gave a lot of work early in the 1980s, both started talking about hot flashes that was an acute problem, but they indicated abated within months or at the most a few years. I'm going to go back to this concept of a few years. All right, now, if you were to ask most practitioners, how long do hot flashes last after the age of menopause? Most would put it 2 years, maybe the outside of 5 years. In 1990 in New York City, the North American Menopause Society was created. I'm a founding member of that particular body, and at that particular discussion, Dr. Cronenberg gave a report on a 1985 B.A. Feldman study of 126 women. The key study was this: 10%, 1 out of 10, had hot flashes extending beyond 11 years from the time of onset. So there was some concern that this was going on, except it was overlooked. We missed it. Duh, we missed it. What I want you to do with the next slide is I want you to look at the slide at the graph, not the writing. When we saw the report from this particular lecture. Right here, peak 1 year after menopause, starting about 1 to 2 years before, and within 3 years, a definite decline. But wait a minute. Let's read the last sentence. 25% remain symptomatic for greater than 5 years. I don't see 4 and 5 out here. So when you look at stuff and you see this particular graph, and this is taken from that particular 1990 Cronenberg lecture, and she's saying 10% had greater than 11 years, 25% greater than 5 years, but this graph says it's over within 3 years. So, as people started to recognize this, they said, wait a minute, maybe we need to go back and look at this. Maybe there's a reason that we're missing something. This is from Polita. This is 2013, looking at the average duration of symptoms and predictors of length of symptoms. And so they took 410 studies to look at how long hot flashes really lasted. But remember, hot flashes start before the menopause. They are symptomatic before that final menstrual period. They are symptomatic enough that people will come to see you about those things. And we were missing them. So they were trying to find longitudinal studies and cross-sectional studies. So of 410 studies about hot flashes, they found final sample size 10. 10 studies. 63 had data, but only 10 studies were made into the 3 were longitudinal and 7 were cross-sectional. Granted, you've got 35,000 participants followed for 12 years, but that means that 400 studies were not used. Here are the studies. You can see this straw staging is that classic statement that shows 1 year before, 2 years before, 3 years before, 1 year after, 2 years after, 3 years after. Bottom line is, as we anticipate, sharply 2 years before the final menstrual period, peaked 1 year afterwards. Conclusion, 50% of women reported having hot flashes up to 4 years after the final menstrual period. 10%, just like Cronenberg reported, based on Feldman, 12 years after. 1 in 10 will be suffering from hot flashes for greater than a decade. So they said we need more longitudinal studies, which I agreed. This is their graphs, and look, you go out here to 10 years, there's still a portion of people having bothersome symptoms. Granted, it's over the peak, but there's still people being bothered. Cole et al. Decided they would look at a longitudinal study. They were going to look at the Melbourne Women's Midlife Health Project. This was a 13-year follow-up. This 13-year follow-up had 381 participants over 9 years, 205 over 14 years. This is their breakdown. Notice most were at 48.6 when they entered in about 2 years to 3 years before. So this is a longitudinal study trying to capture those people before they start the final menopause or menstrual cycle so they can see when the hot flashes occur. Likewise, this study was published in 2009, 13-year follow-up, duration 5.5 plus or minus 4 years. But again, look down here, 13th year of follow-up, 23% of women still reported hot flashes, nearly a quarter. So one of the criticisms of this particular article was that it was Caucasian women only, being done in Melbourne, lower incidence of African American individuals. So Cole turned it over to Freeman, and Freeman utilized the Penn Ovarian Aging Study. Two studies that have come to light over hot flashes over the last couple of years have been the Penn Ovarian Aging Study and the SWAN Study. Study of women across the nation out of Pittsburgh. Rebecca Thurston, who has been a speaker here for us with regard to the Ellie Pryor lectureship, has been leading the Pittsburgh group talking about hot flashes. In this one, they looked at the primary outcome of moderate to severe hot flashes and then any hot flashes. This one had 218 Caucasian and an equal number of African American participants monitored for 14 years. Note, median duration, moderate to severe hot flashes, 10.2 years. These people that had it started near the transition. Those people starting hot flashes just before the final menstrual period had them longer, greater than a decade. Longer time, more intense. Likewise. And what do hot flashes cause? Oh, they're no big deal. They only cause poor sleep, depressed mood, decreased quality of life, worsening depressive symptoms, and signal an onset of major depressive episodes. Folks, hot flashes are real and they cause real problems. Like I said, duration near the menopause transition, 11.57 years. Here's a graph of it. Here are the people that have it right before the transition. They have it longer with more severity. She did a follow-up study looking even further, because this came after our classic 2002 Women's Health Initiative, in which everybody and his brother was saying shortest period of time not to exceed 5 years, 3 to 5 years in the guidelines of NAMS. So she said, okay, let's look at these individuals and see what happens, and let's follow them for a longer period of time. 16 years she's followed them. Longitudinal study. Baseline was at 42, again attempting to capture those people that start into early menopause and start to have a perimenopausal time period before the definition of 5 years. I always try to tell the students it's longer than that period of time for most of my patients. Start to see changes as early as 38. They've got, again, a division of Caucasian and African American participants. The primary outcome was looking at the risk of hot flashes in relationship to that final menstrual period. Again, they followed patients for a considerable length of time. Duration 4.6 to plus or minus 2.9, with the mean duration nearly 9 years. Here is Cronenberg's view, in my opinion, in a graph form that tells the story for real. This is how I now view hot flashes. Yes, you start to see this 1 to 2 years in the straw relationship right before the menopause and the final menstrual cycle, and it peaks in that first 2 years afterwards. That's when most of the people are going to come to see you, which is why we talk about it's not the Women's Health Initiative at age 63 that we're worried about. It's the 49-year-old who's the middle manager trying to take care of teenage children and aging parents who's now not sleeping at night because she's being awakened 7 times a night with a hot flash. And we tell these people that it will be over with in 3 to 5 years, except it isn't. It extends outward to 10 years. So what we've been telling them ain't true. It extends longer for the symptomatic individual. Likewise, one of the other things that we're trying to figure out is what causes a hot flash? What is it? I've talked about this before, especially since it affects so many people. But it was not until 1975 that somebody decided to listen to a woman. And that's basically what they did, finally. And in 1975, G.W. Molnar finally decided that, yes, I'll listen to a woman. This can't be all in their head. Because basically that was telling them prior to that time, oh, hot flashes don't exist. They're just in your head. You're just making this up. They're not really that bad. But in actuality, he finally applied a heat sensor, hence a heat sensing device on the chest of a patient. And guess what? She actually did get hot when she was experiencing a hot flash. But this is not until 1975. In 1991, Robert R. Freeman wrote a very classic article on the physiology of hot flashes. He's the first one to start to take a look at where hot flashes were originating from. Where were the hot flashes actually coming from? And it was his hypothesis, and this is a classic study that I would recommend for anyone interested in looking into this subject, to look at the thermoregulatory nucleus. He felt that this thermoregulatory nucleus was the seat of what would transpire. We fully understand that as people change, as people age, there are changes within the brain that occur at a biochemical level. We know that with the decreasing estrogen, there are some changes that we're going to talk about in a second, but that this thermoregulatory zone, for those people who are symptomatic, changes. Freeman in his article says that that thermoregulatory zone should be wide enough so that the fluctuations within external environmental temperature and core temperature should not have a meltdown for the patient. But when he started evaluating those symptomatic patients, where there should not be hot flashes, where there should not be sweating, where there should not be vasodilation, he found that this thermonuclear regulatory zone was essentially non-existent in symptomatic women. He placed it in the preoptic area of the hypothalamus, which is where most of the work has been done since that time. He postulated that there was a narrower, think non-existent, thermoregulatory zone, and therefore any core temperature change, whether it be from fluids, whether it be from heat from the outside, hot flashes are much worse during our summers, or whether it's from simply taking too hot of a shower, sets off a cascade which opens up the peripheral vasodilation of the body, and we have this heat dissipation type reaction. Maybe we should look at hot flashes not as something that is causing the patient to have simply a flushing, but the body's response to heat and how it dissipates that heat and how we can make that individual better. Likewise, they have shown that during the time of a hot flash, that a woman's activity within her brain starts to slow down. It does not have the same activity. Thus, the patient complains, it is true, I cannot think when I'm having these hot flashes. This is his hypothesis was this was another hypothesis. Elevated brain norepinephrine narrows this particular zone in symptomatic women. Another was a small elevation in core temperature. Core temperature falls, creating shivering. From Packman and Jones, they felt that the estrogen led to a decrease in endorphins and catechoestrogen levels. This increases norepinephrine and serotonin release. This then resets that thermoregulatory nucleus, making the thermoregulatory zone narrower, all looking in this preoptic area of the hypothalamus. Two things we figured out. One, symptomatic peri and perimenopausal women have this narrower thermoregulatory zone. We don't know everything about it. Second, when there is a lack of estrogen, when estrogen is it? The symptomatic women, the ones that are going to have 100 hot flashes a week, have some exaggerated response. But it is in the preoptic area of the hypothalamus. Last year at NAMS, Naomi Rance gave a very fine lecture on her hypothesis. So the next couple of slides are looking at their hypothesis of how this is going on. Dr. Rance has been, and her colleagues, including Dr. Middleton Smith, have been publishing in the Proceedings of the National Academy of Sciences, PNAS, and have been talking about a model of looking at how the hot flashes are created and then ablating certain areas to see if they can prove this. Their philosophy is that in this hypothalamus, in the preoptic area, there are estrogen receptor alpha neurons which then trigger the GnRH. This then affects the pituitary, and as estrogen goes down, there is some effect on the estrogen receptor alpha neurons. And in fact, pre-menopausal and postmenopausal changes show that there is now a decrease in the estrogen receptor alpha neurons. So that's one half of it. We know that the neurons start to go away, and because of that, they're going to affect the preoptic nucleus. Likewise, as the hot flash occurs, there's this activation of heat defense mechanisms, a drop in core temperature. It's also associated with LH pulsatile response from the pituitary. When the onset of vasomotor symptoms occurs with this increased, we start to see it correlating with the onset of hot flashes. It affects the hypothalamic thermonucleation and is a generator of kiss peptide, neuropeptide B, and dynorphin neurons, KNDY neurons, which are in the preoptic nucleus, preoptic pathway of the hypothalamus. So here's the episodes related to the LH and looking at hot flashes, and here's their philosophy. At the menopause, the estrogen receptor alpha neurons start to decrease. You start to see an increase in the kispeptin neurons and the neurokinin B neurons. These go up. Dynorphin neurons also go down. It is these neurons that control the response to a hot flash. And when these things are then activated with the change of LH, that starts to send out the defense mechanism to the body to dissipate heat, and it opens up the peripheral vasal area, causing a much greater response than anticipated. They haven't proved it, but they are trying to come up with it. This is their hypothesis. I think what we've got is that we're starting to try to look at the science of hot flashes, just like we look at the science of labor, to try to prevent preterm labor. If we can figure out which people are going to have difficulty with hot flashes, we may be able to come up with better therapies for them. We certainly are looking at a number, as we'll talk about in a few seconds. So here's what they're talking about. It's all within the preoptic thermoregulatory pathways. These changes occur in this neuron in the arcuate nucleus of the hypothalamus, and it creates the hot flush, or, as I'm now starting to feel like I'm going to start talking about, heat dissipation response. In 2014, there were several new articles that came out looking at small studies at what we're trying to do to prevent hot flashes. This one is talking about yoga. They took 54 individuals and randomized them to either utilizing yoga, health and wellness, or basically waiting, and looked at the decrease in hot flashes during a utilization of a 90-minute for 10 weeks yoga class. Surprisingly, maybe not surprisingly, given what yoga is supposed to do, we saw a 66% decrease in hot flash frequency in those people utilizing yoga. Remember, there's only 54 of these, and they've been evenly randomized, so you're really looking at nearly 17 to 18 individuals. There was a 63% decrease in patients who were basically utilizing health and wellness aspects, not statistically significant, and a 36% decrease in what we'd have to consider the control group. Again, only 54, but looking at yoga. The next article was a discussion with regard to a stellate ganglia blockade, For those of you that might forget about how they do a stellate ganglia, they basically put a needle about that long into and around your C6 vertebrae. They got 40 people to sign up for it, ages 30 to 70, and looked at control group. It was a randomized, double-blind, sham procedure versus actual procedure, looking to see what would happen. They actually saw that in the treatment group, now remember, they're giving them a stellate ganglia blockade by moving the carotid artery and injecting bupivacaine around the stellate ganglia. I'm impressed. They found that the reduction in the treatment group for the people that got it was basically a RR down to 50 with a confidence interval of 0.35 to 0.71. The p-value was less than 0.001. Likewise, when they looked at the objective loss of vasomotor symptoms compared to the sham group, they were able to have a p-value of less than 0.05, which will not really realistically reach statistical significance. They were saying that you could use this as a treatment for hot flashes. I think that you would have to talk long and hard to get your patients to utilize this particular type of therapy, in my opinion. One of the other short, and for the residents, there are many sponsored articles that we have to wade through. This is one of them. This is using a new medication at the time. It's now on the market. This is basidoxifene and conjugated equine estrogen. Basidoxifene is a SERM. It is a protective SERM for the endometrium. You can utilize this without the use of concomitant progesterone. This is their 12-week study utilizing 2 dosages of this particular therapy, looking at quality of life, not an objective decrease of hot flashes or decrease of moderate to severe vasomotor symptoms, but looking at quality of life, using a survey. It is a 12-week type of study. It showed that indeed that the quality of life was improved, but not statistically significant. Similarly, this was a study with regards to the use of paroxetine, raloxifene, and placebo in looking at how a low-dose paroxetine, 7.5 milligrams for those of you keeping score at home, did this improve the use of hot flashes or night sweats. And again, this was done for 12 weeks or 24 weeks, depending on how the patient decided. They found that there were indeed decreases with regards to the number of hot flashes. Again, not statistically significant. Again, utilizing this one as a way of treating with a low-dose SSRI. You might see that on our sample shelves at the present time. And finally, this was a look at a combination of 42 individuals undergoing the use of paroxetine and placebo, looking to see if there was improvement. Again, they saw the improvement with paroxetine, but it was not statistically significant. These are all new studies coming out trying to see if they will improve vasomotor studies. My feeling is these are just a sampling of the ones that we see every year in the menopause magazine that we get monthly and from the NAMS Corporation, and we try to figure out what's to use. So that's a lot of talk, but what does it really mean for you, especially for the residents today? What does this mean? What am I trying to say? We have fought the battle since 2002 about the use of estrogens in postmenopausal patients for the treatment of hot flashes. And it has been a war. It has not even been just a battle. The guiding doctrine has been the smallest dose of hormone therapy for the shortest period of time to treat vasomotor symptoms. Because the indication that still exists for patients undergoing treatment for vasomotor symptoms is symptomatic therapy. If a patient has abnormal response to hot flashes, they need therapy. The problem is that in the estrogen-progestin group, about 4 to 5 years, if one is to look at that particular group, there is a concern for the increase in breast cancer. Heretofore, when we said that vasomotor symptoms lasted only 2 to 5 years, that therapeutic timeline was acceptable. Not only can patients say to you, I can accept 2 years of hot flashes, I think I can get through it, I really don't want to be on hormonal therapy. However, if we accept the studies now coming out, if we look at the literature which says 20 to 25% of these people will have hot flashes for greater than a decade, then the challenge of dealing with hot flashes becomes more unacceptable. We have to figure out how we can keep these patients in a mode of actually just simply functioning. I've had several patients who've had to quit their jobs, who have had significant depressive symptomatology, who've had to go on other major depressive medications, seek counseling to deal with hot flashes. So if we're going to deal with this for 10 to 12 to 13 years, which we've documented, we're not taking care of 1/4 of our patients who've gone through a natural phenomenon. My feeling is that for the future, what we need to do is to start to look at these patients that have gone beyond 5 years. We need first to have really a twofold attempt. One, how do we find out which patients are going to be the ones that are going to last that length of time? Similar to preterm labor, who's going to deliver early? Well, who's going to have hot flashes the longest? The second thing is, I think you're going to still see, because this is something that is out there that's needed, both non-pharmaceutical and pharmaceutical therapies to treat hot flashes, because it is a substantial problem for some patients. I once had a mentor tell me, if you like dealing with change, you're going to love medicine. I think every day we should be learning something new. I take it from our program director with regard. Let's learn one new thing every day. And the deal is that what I've learned in dealing with this is that it isn't 2 to 5 years. Cronenberg even told us in 1990 at the initial inauguration of NAMS, it isn't 2 to 5 years. It's time we listened. It's time we started taking this seriously. And it's time we found out exactly what's going to help these people for the future. As my granddaughter, and I would like to have a shot of my other 2 granddaughters, grows up, hopefully you all will take care of her. Thank you. Questions? Patty?
The studies that you talked about, were they all natural?
All the ones from 2014 were.
Is there any difference
The answer to that is yes. That's where studies have to be done and broken out. Too many studies are taking and putting surgical menopause with natural menopause to get volume for moderate to severe hot flashes so that they can get enough people to treat. I think going forward, we're going to have to start looking. The problem is to get a cohort study of enough people with regard to surgical menopause, truly taking the ovarian tissue out, which we're doing less and less, to see what will happen with those people would be one of the places I would be emphasizing. If you took all the gynecologists, say in Washington County, you couldn't get enough people for a study going forward, even if you used a longitudinal study. The problem is we just don't have the numbers in regards to be able to split those out. When most of these studies are created, they're looking for severe hot flashes, but greater than 7 a day, which if you add it up, that's about 50 a week. So you start to look for specific individuals. I have a number of patients who I talk to and I say, you're having hot flashes. They say, yes, but they're tolerable. Meaning, up to a certain level, they're acceptable. It's when they come in and say, no, listen to me. It's not tolerable. I cannot tolerate this. I cannot handle this. I need some help. And that's when we have to start pulling those people out. And it's very difficult then to get a large enough group. Most of these other studies, 40, 54, 41, just not enough people to get a good handle on what we can do. Which is why we have to have access to large numbers. You have to make it either a meta-analysis or a multi-center. And that takes cooperation and money. So it's easier to do a 12-week study on 40 people sponsored by a drug company than it is, say, multi-center using Cleveland Clinic, other places as large, and then pooling all of the results.
Electronic patch was once listed as a stalwart for patients that could take therapy, and it's falling out of favor, and you did mention it, so what is the current status?
Well, I tell you what, the clonidine patch was utilized, and I tell you what it's been supplanted by. The clonidine patch was used, and it had benefit. Not great benefit, but it had benefit. And I can't tell you right off the hand if I've ever seen a study putting clonidine as a patch, placebo, versus one of the newer SSRIs. What really changed the game with regard to premenopausal breast cancer individuals. Remember, once they got breast cancer, especially premenopausally, they're going to have hot flashes, but they cannot take any type of estrogen. That's off the market. Was when we started recognizing that our SSRIs, specifically paroxetine, which is why they've come out with the low-dose paroxetine as a drug, do a job, less side effects, less anticholinergic effects, things like that. So I don't utilize clonidine. Used to see it being used by medical oncologists in breast cancer patients for hot flashes 20 years ago, 25 I guess now, back in right about the 1990s. But as
The study was 1996. I looked at it for it's only one study showing moderate effect in the first placebo instead of
right. So as paroxetine came along, we used paroxetine. It's better. It has a better side effect profile, and it can be utilized, and now it's in such low dosages, you don't have to worry about people saying, I'm on an antidepressant. Thank you. And congratulations to Dr. Phelps. I assume this is for you. Congratulations. We're trading in a right-handed Brooklyn Dodgers pitcher for Tom Cruise. I think it's a fair trade.